Thank you. I'd like to thank the organizers for inviting me to give this talk. So I have no conflicts of interest, and my objectives today are to talk about common respiratory problems in infants graduating from NICU. Mostly I'm going to talk about chronic lung disease, some of the complications. I'm just going to touch on apnea of prematurity, and then I'm just going to talk briefly about some principles of management. I have a lot to cover, so if I'm talking too fast, please raise your hand and I'll slow down. So if you do the maths, out of the 4 million births in the US each year, there are about 500,000 infants who are less than 37 weeks gestation. Of those infants, 2% of the births are less than 32 weeks. So that comes to a little bit over 80,000 infants. So you're very likely to see these babies in your practice. Now, what has happened over time is that we have had advances in neonatal care, and so more of these infants are now surviving. And if you look at the population of babies who have chronic lung disease or BPD, more than half of them are actually born less than 28 weeks, and about a third of them are less than 1 kilogram in weight. So the role of the primary care provider is so important that there have been 2 documents, an initial one and then an update put out by the AAP. And these guidelines highlight the shared responsibility for the care of these infants between the primary care provider and the neonatologist. They stress the need for communication between the 2 teams and the importance of that continuity of care when the babies are discharged from the NICU. So well, let's talk about the definition. What is chronic lung disease? It's a term that we use to describe mostly the effect of prematurity on the respiratory system. It's actually a vague term, and it includes a wide spectrum of disorders. Now, please note that other lung injury in the neonatal period can also give you chronic lung disease. But the majority of infants who have chronic lung disease are going to be ex-premi. Now, I'm going to use sometimes chronic lung disease, sometimes BPD, and people use these terms sort of interchangeably. But chronic lung disease talks more about the clinical picture, whereas BPD is really the histopathology of this condition. So what happens is very early in life, around the time of birth, you have infection, inflammation, some insult that's happening there, and that's this red part. And then this starts to resolve over the next week to a month. And then you have a process of repair and remodeling here in the blue. And that can take a long time. That can occur in a month, but it can take up to a year or more. And then hopefully we have lung growth and development that will continue that repair and that healing process. So BPD was initially described by Dr. Northway in 1967, and he was a radiologist, and so he described these infants who at 4 weeks of age were still either dependent on oxygen or on ventilation, and they had radiographic abnormalities. Now, the population that he described were actually older infants. These were infants who were more than 32 weeks gestation, and they had pretty bad lung disease. But what has happened over time is we have recognized that a lot of oxygen actually isn't good. It harms the lung, and it causes BPD. Very aggressive ventilation strategies also harm the lung. We've recognized the role that infection antenatally, what that causes. And so nowadays in NICU, you have much more gentle ventilation strategies. People are very careful with the use of oxygen. And then surfactant, of course, came in the 1990s. And so what we're seeing nowadays is a different clinical picture. And so what you have here, you have this old what we now call the old BPD. These are infants who are more than 28 weeks. They had really severe RDS at birth. And if you look at them either on X-ray or post-mortem, you will see alternating atelectasis with hyperinflation. So Job and his group in 1999 proposed that we call the infants that we see nowadays the new BPD. Now, these are very preterm infants, and in fact, some of them at the time of birth may have very little RDS, but they go on to have progressive problems. They develop an oxygen as well as a ventilation requirement, and sometimes this can last for a long time. So when you look at it from a developmental standpoint, this is like a schematic of how the lung grows, starting from the embryonic phase and going all the way to the alveolar phase. The old BPD used to occur late in the saccular phase when the alveolar ducts, the acini, are being formed. And the new BPD, you can see, is occurring at the end of the canalicular phase and early in that saccular phase. When you look at this from a histologic standpoint, the old BPD, you had a lot of airway injury and inflammation. You can see here there's a lot of cellular infiltrate. There is marked smooth muscle hyperplasia, a lot of fibroproliferation, a lot of remodeling of the pulmonary arteries. On the other hand, you contrast that with the new BPD. You have much milder airway smooth muscle thickening, not a lot of fibroproliferation. You have fewer arteries and fewer alveoli. And so what we're seeing here is an oversimplification of both the alveoli and a reduction in the pulmonary capillary bed. So following that, there was an important conference held at the National Institute of Child Health and Human Development that came up with a summary where they proposed new diagnostic criteria. And so they divided this into the less and over 32 weeks and proposed that the time point at which we should assess these infants should actually be 36 weeks post-conception or discharge home. And then they further subdivided these infants into mild, moderate, and severe, depending on whether or not they needed oxygen, how much oxygen, and whether or not they needed any positive pressure ventilation. Now, the reason for that change in the time point was because it was felt that this was more relevant to their future pulmonary outcome. So what are some of the complications that we see associated with this? This is a pretty common complication, this is a bronchoscopy photo that shows you tracheomalacia. What you can see here is you see flattening of this AP diameter. Now, this is difficult to diagnose clinically unless you do a bronchoscopy. It's due to barotrauma, infections, the presence of an artificial airway. And the way that these infants can present is they will have sudden episodes of cyanosis or an ulti. And they have what we sometimes call BPD spells. So the baby will look fine, you will piss them off, and they will go dusky because basically they clamp down. Another way they can present is with wheezing that's unresponsive to bronchodilators. On X-ray, you may also see areas of recurrent atelectasis. Now, an important thing to note is these babies can be very difficult to wean from ventilation as they get older. The pictures here, these are uncommon complications. In the past, they used to see a lot more subglottic stenosis. The incidence was maybe up to 12%. But we, again, have recognized that the importance of not damaging this area using a smaller ET tube. And so nowadays, the incidence really is less than 1% of intubated infants. Now, this can be associated with stridor, with apnea, with bradycardia. Tracheal and bronchial stenosis, it's hard to put a number to that, but again, we're much more careful about suctioning and avoiding trauma to the airway. So, pulmonary artery hypertension is one of those conditions that's actually much harder to recognize. The reason that it occurs is thought to be that you have impaired production of nitric oxide and vascular endothelial growth factor. And so in figure A, what you see here is a normal pulmonary vascular bed. You can see how it branches out, and you have all these very nice fine branches. In picture B, what you see is that you have a marked reduction in this pulmonary vascular bed, especially blood vessels that go into the alveoli and the intra-acinar arteries. So there seems to be an arrest of development. When you look at this under the microscope, what you see is that there is pulmonary vascular remodeling, where the arrows are. These are blood vessels. There's also an increase in the resting tone of the pulmonary artery smooth muscle. Now, remember that this is going to be seen in infants with severe BPD. Now, the long-term effects of this can be pretty significant. It can be associated with congestive heart failure, and the mortality really is pretty high. So moving on, growth and nutritional failure, we see this very commonly. We continue to see this in the infants that we follow in the clinic, who you will be seeing in your office. And really many factors, as you can see, will contribute to that. These babies sometimes don't tolerate a fluid load very well. You have to restrict their fluids. They can have swallowing dysfunction. Their work of breathing is increased. Their energy requirements are high. And then you add in things like anemia, infections, other system abnormalities, and you really have a setup for bad nutrition. I'm not going to talk a lot about reflux because I think Dr. Dabari is going to be talking later today about this topic. Just to say that reflux is almost universal in premature infants, thought to be associated with a lower esophageal sphincter muscle tone, and can be made worse by medications that we give them, such as caffeine. Now, it can cause asymptomatic aspiration, bronchospasm. It can cause apnea and bradycardia. However, there's been a number of recent publications that have challenged that relationship. And so all I will tell you is this is a very controversial area. And the episode of apnea, the episode of reflux, don't always appear to be temporally related, even though if you were to put acid into the upper esophagus, you are going to get laryngeal adduction if you do this in the lab. So With all that, finally it's time for our NICU baby to leave the NICU. This process needs to be very well organized. This is really critical to successful transition to home after prolonged hospitalization. The severity of the disease is going to vary. You're going to have some infants who just go home with nothing more than a few medications. Then you're going to have others who are going to be on a home ventilator. Now, I just graduated my oldest 2 days ago, but unfortunately he's going to be coming back home very frequently, and these babies do the same. They go out and sometimes they don't last a week or two and they're back in the hospital. Sometimes they last a little bit longer, at least until the winter season. So the parents, I think, see it as a failure, but when I see them for the first visit, I tell them, look, this is going to happen. The first year is going to be really tough. You just need to hang in there, and it will get better. So recurrent hospitalizations are very, very common. Again, it's related to the severity of the BPD, the number of comorbidities, but again, depending on which source you read, it is more than 50%. In some babies, it approaches 80% for that risk. So viral infections actually trigger most respiratory exacerbations, and they're associated with significant morbidity and mortality. RSV is one of the most dangerous viruses, and so we have fortunately had Synagis, and immunizing these babies with Synagis during the November to April season has markedly decreased the number of RSV-related hospitalizations. In fact, we've done a pretty good job with that, and so now rhinovirus, which is just the common cold virus, has become the most common one that we identify in children coming back for rehospitalization. Now, our emergency room doesn't always screen babies for viruses. The pulmonologists tend to screen them, and I think we do that not only for the sake of knowing, but also for infection control reasons when they come into the hospital. So I'd like to move on and just talk about some of the management principles. So oxygen is one of the oldest, one of the most commonly used therapeutic agents, and it's really a mainstay of therapy. It allows for body growth, lung growth. It promotes repair of the developing lung. It enables the baby to have some activity. And if you have some pulmonary hypertension, it will also lower the pulmonary artery pressure and the right ventricle workload. If you deprive these babies of oxygen at a time that they need it, you can see that they're not going to grow as well. They're not going to feed as well, and they may have issues with pulmonary hypertension. There's been a lot of debate about what the ideal oxygen saturation is. So I think we know now that in early life you want to probably shoot for the high 80s, maybe low 90s. Too much oxygen is not good. But there's a fine line, because if you give too little, you'll also increase the mortality. However, once these babies are beyond 32 weeks or they leave the NICU, what do you want to maintain them at? And again, that's been a controversial area. There's one study done by Dr. Askey and colleagues, and they looked at more than 350 infants. And the conclusion was that if you kept these infants with a saturation of between 91 and 94, rather than in the high 90s, that actually was adequate. Having them at a higher saturation did not confer any benefit, and these infants would continue to need oxygen for a much longer period of time, and so that obviously would increase the healthcare burden. The only group that you do want to maintain higher oxygen saturation is, of course, the babies that have pulmonary hypertension. So the majority of these infants are going to wean off oxygen somewhere between 6 and 12 months. So another study that was done, they sent questionnaires to pulmonologists in many academic centers and asked them, so how do you wean oxygen? And sadly, there is no formal protocol in most centers, either on how or when to wean oxygen. So every center has devised their own plan, but some of the things you want to look at is if the infant is growing, the infant isn't having frequent respiratory exacerbations, your SATs tend to hang out in the low 90s to mid 90s, then that's usually a baby that you can continue to wean the oxygen until you're on room air. Now, note that an inability to wean may suggest that you have either ongoing lung injury, such as from aspiration, or another undetected problem, like a cardiac problem. Now, what about bronchodilators? There are only a few studies, and there are mixed results. But we do know some things, that infants with chronic lung disease have an increased prevalence of airway hyperreactivity. They also have lower airway obstruction that's at least partially reversible with bronchodilators. So the two groups that we use are going to be beta-2 agonists as well as anticholinergics. These will improve the compliance of the airways because they decrease your resistance. When these babies have viral infections, they also may respond to bronchodilators. So what I would say is that it's worth trying them. If the baby responds, then you can go ahead and use it. If the baby doesn't respond, then you can legitimately make the argument that you don't need to use them. Note again that babies with bronchomalacia may get worse because you're going to relax the airway smooth muscle. These babies may respond more to ipratropium. We don't tend to use methylxanthines a lot, but they can be considered in rare instances. They improve the contractility of the diaphragm, and they also have a mild diuretic effect. So steroids, these are even more controversial. There was a time, again, when they used steroids very early on to wean babies off the ventilators, but then noticed that you had bad neurocognitive outcomes. And so, again, there was a policy statement that said, nope, we do not want to use steroids. A more recent statement, looking at the risks and the benefits from the AAP, was a bit more positive. However, the bottom line is you don't want to give them very early, at least in the first 2 weeks of life, and systemically. For inhaled steroids, there's really very little evidence. We use them, but whether or not they affect the long-term outcome is really not clear at all. Diuretics, we tend to use two groups. We use furosemide. These can be used either daily or every other day. For long-term use, though, we tend to use either thiazides alone or the combination of spironolactone and thiazide diuretic. That decreases the oxygen requirement. You will need to monitor electrolytes as well as side effects if a baby's on diuretics. Again, there is no consensus at this point on what you will wean first, whether you will wean the oxygen or the diuretics. When I've asked parents, they tell me, I'd rather be giving the baby a medicine twice a day than be lugging around the oxygen cylinder. And so again, I've tended to wean the oxygen first personally. So nutrition is very important because we always say if your body doesn't grow, your lungs don't grow. The needs are going to vary amongst the prematurely born babies, but we know they need at least 150 kilocalories per kilo per day. So in order to achieve that, you're either going to need to give them enriched formula or fortified breast milk, because they don't tolerate volume very well. Some of these babies are going to need to be fed by NG or G-tube because of their inability to suck or to overcome a dysfunctional swallow. Now, they usually catch up in the first 2 to 3 years of life, and if the babies catch up quickly, that's actually associated with a better neurodevelopmental outcome. However, when they looked at ex-preemies who are now children and adults, especially those who were very low birth weight, they tended to be smaller than their peers. So reflux treatment for that is really pretty standard, so I'm not going to go into it. What about the babies with severe reflux? I can tell you that personally I really struggle about telling a family that their child needs a Nissen. I don't like Nissens. The kid can't vomit easily, and they feel very uncomfortable. If it's over tight, you have problems. So unless we've bronched the child, we've demonstrated over and over again that this child is aspirating, we don't tend to promote Nissens. Again, do you need to treat? That's a very controversial area, I will tell you, and maybe Dr. Dabari will say some more, but he talked to our group recently, and he said not all babies really need to be treated. Some do. Pulmonary hypertension, I send these infants to the team at Children's who specialize in pulmonary hypertension. The mild ones are just going to need oxygen. The more severe ones are going to need pulmonary vasodilators. The mortality, though, is still fairly high. So a few infants are going to go home on chronic ventilators, and we're going to be seeing these babies. The pros of this is that you allow the baby to grow, allow the lungs to grow, the kids can develop. When you have a cannula in your nose giving you high flow or CPAP, you can't really do much. But you'll be surprised how much babies can do hooked to a ventilator. You can also decrease their caloric needs because you're taking away that work of breathing. Now, it requires a very high level of home care. You have all the complications associated with having a trach, being hooked to a vent, and it really is not a guarantee that your morbidity is going to be any less or that your survival is going to increase. So I'd like to shift gears and talk quickly about apnea. Now, apnea is defined as a pause for more than 20 seconds, or if it's less than 20 seconds, as you see here in this snapshot of a sleep study, it has to be associated with a bradycardia, a change in tone or movement, or an oxygen desaturation. And what you see here is you have flattening of these 3 bottom channels, so you have no effort and you have no airflow. It's actually very common. It affects 25% of preemies and thought to be the result of immaturity of your control centers. Again, most babies are going to outgrow this, hopefully by the time they go home, but if not, they're going to be on an apnea monitor, maybe caffeine. And once these babies come back to the clinic, we download the monitors, we see that they're not having events, then we stop the caffeine usually first. We monitor them maybe for another month or so, and then if they have no events, we will stop the apnea monitor. There's been a lot of discussion. Do you need to do a sleep study every time you want to stop a monitor? We used to do that, but not quite as frequently. If you think that there is another sleep-related breathing disorder, then by all means, a sleep study should be requested. However, I will tell you that the sleep study, there's nothing very specific on it that is going to predict for you whether or not you need to continue monitoring this infant. And so we tend to rely on the downloads. So what about sleep hypoxemia? That's actually a problem that we don't often detect, but these are intermittent episodes of hypoxemia during sleep despite a normal saturation when the child is awake. They occur more in REM because when you're in REM, your muscles are atonic, and so you can't compensate for upper airway obstruction. If you have sleep hypoxemia, this is going to increase the baby's energy expenditure and impair their growth. And it can also affect the function of the right ventricle. So moving on, that has some links with SIDS. This is from the SIDS task force that was chaired by Rachel Moon. So what's thought to happen is that you have a vulnerable infant at a critical stage in their life, and then you have some stressor that then leads to SIDS. So we know that prematurity is a risk factor for SIDS. The reason being that some infants with BPD have impaired vestibular-mediated cardiovascular control, so they don't control their heart rate, their blood pressure like they should. They also have impaired reflexes to hypoxia, and what happens when they sleep is that they have these intermittent episodes of hypoxia. What we do see is that in ex-premature infants, the risk of SIDS is shifted, so it's about 4 to 6 weeks earlier than it is in term infants. How do you manage these babies? Same as term infants, you sleep supine, you avoid the same risk factors, the bedding, the smoking, and so forth. But it is important to ensure that they're adequately oxygenated, and unfortunately, if you monitor them, that has not resulted in a decrease in the rate of SIDS, neither in preterm nor in the general pediatric population. And again, getting a sleep study, there's nothing specific that you're going to see that's going to predict whether this baby is going to have SIDS or not. So in summary, the infants who are discharged from the NICU, as you can see, are going to face many challenges. They're going to require continued comprehensive respiratory clinical care. The primary care pediatrician plays a key role in this in providing optimal treatment by coordinating that transition of care from the NICU and the neonatologist to the home, by providing direct medical care, and then by facilitating the ongoing care of these infants by subspecialists and other healthcare professionals.